In our next ECG, just by looking at the rhythm strip, we can tell the rhythm is irregular. The RR interval at this point is 2 big squares, and here just under 5. So we can't use the 300 divided by RR interval formula to calculate the rate. Instead, we use another method. The standard rate by which ECGs are printed at are 25 mm per second. This works out the ECG being worth a total of 10 seconds. So if we count how many heartbeats are present on the ECG, we can then times that number by 6 to estimate how many beats in 60 seconds. Here we have 16 beats, so 16 times 6 is 96, so we can approximate the rate as 96 beats per minute. Next thing we need to look out for is P waves. When looking for P waves, we need to look for a positive deflection before a QRS complex, which is consistent in its morphology throughout the lead. Some of you may point to this part of lead 2 and say that P waves are present. However, we can't say this shape is being consistently present throughout the lead. Instead, these are most probably fibrillary waves. So we can conclude P waves being absent in this ECG. Given the rhythm is irregular and P waves are absent, we can safely label this ECG as atrial fibrillation. Just for completeness, we'll quickly run through the remaining factors. Given absence of P waves, we can't calculate a PR interval, QRS complex is about 3 small squares, and no ST elevations can be seen. The axis is deviated towards the left. For this ECG, we won't run through the whole system again, but just by visually looking at it, we can see the RR interval being variable, and the presence of many P waves before a QRS complex being generated. This appearance of P waves is known as a sawtooth appearance and is diagnostic for atrial flutter. Now, let's start looking at limb leads with chest leads. As always, we will start with a rhythm strip at the bottom. The rhythm here is regular. There's about 3.5 boxes between each R wave, making the rate 85 beats per minute. P waves are present with consistent morphology. PR interval and QRS duration is about 3 boxes. All limb leads are positive, making the cardiac axis normal. And no ST elevation or T wave inversion are seen in the limb or chest leads, making this a normal ECG. Just by looking at the first 3 heartbeats, we can tell the rhythm is irregular here. However, P waves are present, hence this is not atrial fibrillation. There are 11 beats across this ECG, which is 10 seconds long, hence the heart rate is 66 beats per minute. PR interval and QRS duration is normal. Lead 3 is negative, with 1 and 2 being positive, making it a left axis deviation. The ST segment in lead 2 is elevated, which can be hard to see. However, if you look closely, you can see the ST segment being above the isoelectric point. In V1, we see inverted P waves and the ST segments depressed. Moving on to V3 and V4, we see prominent ST elevations, making a significant ECG for a STEMI. This ECG is also diagnostic for a STEMI. However, compared to the previous STEMI, the location for the ST elevations are different, which is significant in determining the location of the heart attack. Leads 1, AVL, V1 and V2 all have ST elevations. Lead 3 has a ST depression and a T wave inversion. Now, if we use the knowledge we learned earlier about location of ECG leads, we can correlate the location of ST elevation to the location of the infarction. Lead 1 looks at a charge across the chest from right to left, so any changes there represents an infarction in the lateral aspects of the heart. Leads 2, 3 and AVF all look at the heart inferiorly. Lead AVR is non-diagnostic, and AVL, as the name suggests, looks at the heart from the left, so the lateral aspect. V1 and V2 look at the septal aspect. V3 and V4 look at the anterior aspect, leaving V5 and V6, which like lead 1 and AVL, look at the lateral aspect. Now let's have a quick look at the ECG, in particular the ST segments. Leads 1, 2, 3 and AVF all have ST elevations, so just by purely looking at these limb leads there is a lateral and inferior aspect. But V1, 2, 3 and 4 have ST depressions. These ST depressions in V1 to 4 are what we call reciprocal changes. The infarction is taking place posteriorly, so instead we see the opposite changes to an ST elevation. Leads V5 and V6 also have ST elevations, further suggesting there's a lateral aspect involved too. So we have inferior, lateral and posterior changes in this ECG. Hence, we can call this a myocardial infarction with inferior lateral segment and posterior involvement. The answer for this ECG lies in the rhythm strip. The PR interval is much more than the normal 3 to 5 boxes. Finding a prolonged PR interval signifies some kind of heart block, and to determine which type of heart block it is, you have to look at the pattern of prolonged PR intervals. The PR interval is consistent throughout the ECG, and each P wave is followed by a QRS complex. This is a definition of a first-degree heart block. This ECG is an example of a second-degree heart block. We'll pause the video again for you to figure out the pattern for a second-degree heart block. If we look at this beat, we can see the PR interval is about 6 boxes, but all the beats after increase in duration, until you see this P wave, which isn't followed by a QRS complex. And that is the definition of a second-degree heart block, type 1. Each successive PR interval prolongs with a QRS drop, at which point the PR interval resets. In a second-degree type 2 heart block, the PR interval is consistently prolonged with the dropped QRS. P waves and QRS complexes in this ECG have absolutely no relationship. This is an example of a third degree or a complete heart block, where the atrial and ventricular relationship are independent of each other. The quality of this ECG is really poor, but the abnormality is still clearly visible. If you look throughout the ECG, the QRS complexes seem bigger than a normal of 3 boxes. This signifies that there's a conduction problem within the ventricles. When there's a prolonged QRS duration, the most important leads to look at are the chest leads, in particular V1 and V6. The QRS complex in V1 seems to be extremely positive than a normal V1 lead. And V2 has a weird shape, where the QRS complex has no downward deflection to start with. Instead, it first deflects upwards, then downwards, and lastly, back up. This pattern is known as an RSR pattern and signifies a right bundle branch block. If we look at a clearer example, we can again see the RSR pattern in V1. The RSR pattern can also look a lot like the letter M. Whereas in a right bundle branch block, the QRS complex in V6 resembles the letter W. In comparison, a left bundle branch block has the opposite pattern. V1 looks like a W and V6 looks like an M. To remember which way a right bundle branch block goes and which way a left bundle branch block goes, you need to remember Marrow and William. Marrow, which has a double R, is for a right bundle branch block, and given the first letter is M, that's the pattern you see in V1. the last letter being W, that's the pattern you see in V6. William, on the other hand, has a double L, and that's for a left bundle branch block. William begins with a W, and that's what you'll see in V1, and ends with an M, so that's what you'll see in V6. Any findings on an ECG should be compared with the previous ECG. In particular, any new findings like a T-wave inversion or left bundle branch block could be significant for an acute coronary syndrome, and relevant investigation should be requested. The rhythm in this ECG is regular. However, the rate is about 170 beats per minute, making it a tachycardia. Having a broader look at this ECG, you can see there is only one type of wave here, and given the height of these waves, we can safely interpret these to be of ventricular origin. In addition, the waves seem extremely broad, and this is what you'll see in something called a ventricular tachycardia. In comparison, this ECG is also tachycardic, but the complexes here seem to be narrower than the previous ECG, which is significant for a supraventricular tachycardia. A supraventricular tachycardia means the origin of the tachycardia is above the bundle of His. Now, look at this ECG and see how many different types of waves you can identify. There's a QRS complex and a T wave. You can't see any P waves, and this is because the P waves are being hidden by how fast the heart is going. This ECG has absolutely no fixed pattern. It appears very fast, and each wave seems to be of a weird shape. An ECG like this is as worrying as it gets, because this patient is in ventricular fibrillation. The ventricles here are quivering. They are trying to generate a full heartbeat, but failing to do so. And the inconsistent shape suggests that each beat seems to be conducting in a different manner. There is absolutely no synchrony. Even if you try to follow the steps we talked through earlier, it's hard to follow because our eyes can't get past how big these waves are. However, let's just still go through all the steps. The rate is about 120 beats per minute, with a regular rhythm. P waves are present throughout the rhythm strip and have a consistent shape. PR interval and QRS durations are within range. No ST elevations can be seen in any of the leads, and no T waves are inverted. But instead, the T waves seem to be very high. The word we can use is peaked T waves, and these changes are indicative of hyperkalemia. Other ECG changes that can be typically seen in hyperkalemia include small P waves, prolonged PR interval, and a broadened QRS complex. Any ECG changes related to hyperkalemia need to be corrected as soon as possible, as if this progresses, the patient could go into ventricular fibrillation. Now, one more thing to add to the checklist is QT interval. QT interval is the time between the start of the Q wave and the end of a T wave. So, to put it another way, it measures how long it takes for the ventricles to start depolarization and fully repolarize. If left unnoticed, a prolonged QT could lead to TDP or ventricular fibrillation. In the ECG in front of us, we can visibly see the T waves being far away from the QRS complex, but we can't use this at face value. How long or short a QT interval may look depends on how fast or slow the ventricular rate is. If the heart is going fast, the QT interval may look smaller, but if it's going slow, it may seem prolonged. Instead, we use a formula to calculate the corrected QT interval. We take the raw QT interval and divide it by the square root of the RR interval. Fortunately, you don't have to perform this calculation. Most ECG machines calculate this number for us. Other causes of prolonged QT interval include pharmacological drugs, hypokalemia, hypomagnesemia, and congenital causes. Thank you very much for watching this video on ECG. I hope you learned something new, and if you did, please like, share, subscribe, and fill out the survey found in the description box below.